This is a presentation about the Johns Hopkins Mobility Program that will be starting at the end of June to replace progressive upright mobility. The reason that we're doing this is because we know that bed rest is bad for patients. It increases the risk of blood clots, pneumonia, skin breakdown, contractures, and decreases muscle mass every day that a person is in bed. So with Johns Hopkins Mobility, it is a founded study that shows that the more we move people daily, the better it is for their overall health and decreases their hospital stay. So the first part that a nurse has to fill out is the AMPAC 6 clicks. It's 6 questions that help determine if the patient's at risk for developing complications of immobility. The raw score then auto-populates in Epic after doing the 6 clicks, and that will produce the highest level of mobility goal. So this is the daily minimum mobility goal for each patient. It's done every shift, and it also will give you a recommended assistive device. When you hover over this particular row, you'll see this exact example. So doing the AMPAC 6 clicks, like I said, the RN will do this to identify the patient's current mobility status. So it's not what their baseline is, it's what they're currently able to do today. So from the simplest movement, turning from back to side while lying flat in bed, to a more complex movement like climbing 3 to 5 steps utilizing a railing. The nurses will use a scale to determine that, which will produce the raw score. And again, the raw score will be auto-populated into the mobility goal row by Epic. So this tool will help guide all staff members, keeping everyone from physical therapy to nursing to providers all on the same page. This AMPAC 6 clicks should be done at the beginning of every shift. The next part that the RN is responsible for is the assistance level. It ranges from total assist to no assist. In the middle are terms a lot and a little. These can be quantified using percentages. How much percentage does the patient do of the work, and how much percentage are you having to help them with? For example, someone who is minimal assistance level performs about 75% of the work on their own, versus someone who provides or requires maximal assistance needs 25%. When we're conducting this assessment, utilizing our clinical judgment and safe patient handling skills when we're mobilizing the patient are very important. The highest level of mobility goal is what we are hoping that the patient will be able to meet. But because it's a minimum, people may exceed it or may not quite meet it each day. Question: what if the patient is not observed doing the particular activity? That's all right. The tool was built to still be effective regardless of whether you actually saw the patient doing that activity or not. What is expected is that the nurse uses their clinical judgment along with patient and family input to determine what the appropriate level would be. For example, most nurses will not be bringing patients to any stairwell to be able to count if they're able to do 3 to 5 steps. But if you were able to mobilize your patient around the room, around the floor, and then get the input from the patient and family, you would be able to discern what would be an appropriate answer. So again, the 6 clicks needs to be done at the beginning of every shift. Physical therapy will also do the 6 clicks on their primary evaluation and every 7 days after admission. What physical therapy will not document is the highest level of mobility performed, which is the very last row. That must be documented by nursing to include nurse aides and nurses every time the patient is mobilized. For example, the patient may be fatigued in the morning and only achieve a level 4, versus in the afternoon they attain their goal level of 6, and then by the evening they have more energy and they're at a level 7. So that would just need to be documented in that highest level of mobility performed that day. Healthcare providers will write orders, for example, AMPAC, nursing to assess AMPAC and Johns Hopkins mobility Q shift, and nursing to mobilize the patient's Johns Hopkins mobility level, and then the frequency twice a day, 3 times a day, etc. Always follow your provider-specific mobility order, in particular in relation to orthopedic surgeons. Whatever orders they put in regarding that particular body part, always follow that order. If the patient is on bed rest, the AMPAC 6 clicks can still be evaluated. Regarding the frequency, when physical therapy does a session, that will count as towards the total number of mobility sessions for that day. This is an example of the mobility daily goals that will be placed in the patient's room. As you can see, it goes from bed rest all the way up to freely ambulating about 250 feet or more. So one really important thing about AMPAC 6 clicks is that we do not hold the use of assistive devices against the patient. If the patient needs to use an assistive device like a walker or a cane, that's totally acceptable, and it does not give them a lower score. What we want to see is that they're progressing from day to day. Every time that they are being assessed, that they're able to meet their goal and hopefully exceed their goal. If they're not, then the patient needs to be reevaluated by physical therapy or by their provider to determine why they are unable to consistently not meet their goals. Other things for you to consider is the amount of distances that patients will be walking. If a patient walks the entire nursing floor, that would be 400 feet. This diagram was produced by physical therapy to help assist nurses and other physical therapists with the numbers of distances that patients write. This will be provided for all of you. So for example, a patient at an HLM level 1 or 2 is someone who is on bed rest or they're a full dependent transfer. If that's the case, a level 1 or 2 is not able to walk. So what would be appropriate for them would be range of motion exercises. Levels 3 through 5 involve more movement to include sitting at the edge of the bed, moving to a chair, or standing for 1 minute. Again, the use of assistive devices does not count against the patient. It's perfectly acceptable for a patient to use an assistive device. Here's an example video of a patient. You can see they're using the railing and also the nurse's hand to get to the edge of the bed, but they still were able to get to the edge of the bed with minimal assistance. So that would be a level 3. Some things that patients should be encouraged to do would be sitting at the edge of the bed, eating, brushing their teeth, washing their face. What we really want to do is increase the total amount of time spent outside of the bed as much as possible. Here's another example of a patient wearing a gait belt, utilizing the walker to turn and pivot. The nurse encouraging the patient to use the side rail of the bed in order to sit. So this would be a level 4, moving to the chair. Question: my patient's mobility goal of the day is a level 6, which is only 10 steps, but my patient's able to walk 25 feet. Do I limit my patient's mobility to a level 6, only 10 steps? The answer is no. It's a minimal goal. If a patient walks 150 feet, took a seated rest due to fatigue, and then walked 100 more feet, how many feet do we give them credit for? The answer is 250. They took a rest due to fatigue. That's acceptable, but it's still considered part of the same session. If a patient walks independently in the hospital room but requires a walker, the basic mobility item number 5 is scored as none. No assistance required. The answer is yes, none. Does a patient have to be independent with ambulation to score a 6, 7, or 8? What if they require assistance or supervision in order to ambulate safely? So it's fine. The patient does not have to be totally independent to score a 6, 7, or 8. They may use assistive devices or redirection or even assistance from other people. Thank you for listening.